In this lecture, we're going to talk about polyostotic tumors or multiple bone tumors that all look alike. Just a fancy way of saying the same thing. So we've talked about in some of the other lectures how you come up with a reasonable differential diagnosis based on what a tumor looks like, based on its location, based on its morphology, based on its matrix, based on any aggressive features it may have. And those are all going to help us in talking about polyostotic things as well. Also, however, when you see a polyostotic lesion, you're going to have a separate differential diagnosis because it's a limited list of things that are liable to give you a polyostotic lesion. So we'll go through both benign and malignant processes that will give you a polyostotic tumors. We can really break these down into whether they're benign or malignant. Now, by far and away, the most common things that you're going to see on a day-to-day basis are malignant polyostotic things, and they're usually going to be Mets or multiple myeloma. You see these day in, you see these day out. They're super common. They're by far the most common tumor you're likely to encounter in your practice. And a lot of the other things we're going to talk about on the benign polyostotic list are much rarer, and you may not ever run across them at all. But at least we'll hopefully have heard of them. So we'll run through some of the more common benign polyostotic things, and then just briefly talk about the malignant things, which is pretty straightforward, really. All right, so this is a pretty good list of things that are going to give you benign polyostotic lesions. I think if you were familiar with all the things on this list, you wouldn't have any problem approaching multiple polyostotic lesions which were benign. So what are they going to be? So certainly fibrous dysplasia. Fibrous dysplasia is not that uncommon, and there are polyostotic forms of fibrous dysplasia. Multiple enchondromas, much rarer condition. Certainly a single solitary enchondromas are pretty common in themselves, but the multiple enchondroma syndromes are quite rare, but we'll talk about those. Multiple osteochondromas. So again, a single osteochondroma is not an uncommon lesion. Multiple osteochondromas or hereditary multiple exostosis is a much less common disease. Non-ossifying fibromas, again, these are single non-ossifying fibroma is a pretty common thing. This will crop up, but it's pretty rare to have multiple non-ossifying fibromas. But nonetheless, there are conditions where you do develop those. Brown tumors associated with hyperparathyroidism, that's probably not so uncommon, as hyperparathyroidism is a pretty common condition. So you can see brown tumors associated with those. Multifocal osteomyelitis, again, infection can mimic bone tumors and is going to be on many of your differential diagnoses for other bone tumors, and so you can certainly have multiple areas of osteomyelitis. And then Langerhans cell histiocytosis, or EG, is pretty rare, but will also appear as a multiple lytic lesions as a polyostotic condition. Malignant polyostotic conditions, as I said, are pretty straightforward. It really just boils down to is this a metastasis of some sort? And if so, can we maybe think what it could be based on how it looks? And then multiple myeloma. Those are the main things. Other things, lymphoma, leukemia, these could do it as well, but Mets and myeloma are by far and away the most common malignant polyostotic conditions. These aren't really bone tumors. These are just kind of miscellaneous things that can kind of look, that are bone abnormalities or bone lesions. Not really a bone tumor per se, but they are, because there can be multiple of them. We'll just talk about them in here. So hemangiomas are pretty common, just kind of incidental findings, but you can have conditions where you have multiple hemangiomas. Osteopoikilosis is a rare condition where you have basically multiple bone islands scattered throughout the skeletal system, as you can see here. It's kind of one of these things would easily characterized as a bone island, and they have multiple of them. So osteopoikilosis is a type of skeletal dysplasia where you have multiple bone islands. As is meloriostosis, another skeletal dysplasia where you have abnormal sclerosis of the bone, which goes along sclerotome. So we'll talk about some of those. All right, so we'll just go through these one at a time, our benign polyostotic conditions. Fibrous dysplasia is the first one we'll talk about. So polyostotic fibrous dysplasia, if you remember when we talked about a monostotic fibrous dysplasia, it tends to be a long lesion in a long bone. It tends to be olytic in appearance, um, and it's often associated with weakening of the bone, and you'll get bowing abnormalities, as you can see here in this patient with polyostotic fibrous dysplasia. You have this geographic lytic lesion, which is affecting a long segment, nearly the entire tibia, and also a shorter segment of the fibula, and is creating these bowing abnormalities in both the tibia and fibula. And these bowing abnormalities are classic of fibrous dysplasia with this underlying lesion. We'll go back just to show you this one, because this was a picture also of fibrous dysplasia, polyostotic fibrous dysplasia. You can see it's affecting multiple bones in the pelvis and also the proximal femur. The proximal femur is a favorite location for fibrous dysplasia, and this is giving you one of your classic shepherd's crooks deformity. The femur is bowed and not normal in morphology, and it looks like an old gnarled wooden stick that a shepherd walks around in the ancient Athenian hills or something like that. So shepherd's crook deformity in polyostotic fibrous dysplasia. Two of the conditions which are associated with polyostotic fibrous dysplasia are McCune-Albright syndrome and Mazur-Brown syndrome. McCune-Albright syndrome is found in girls. It's associated with precocious puberty, um, and cafe au lait spots, and they'll have a polyostotic fibrous dysplasia. And the other one, Mazur-Brown syndrome, is again polyostotic fibrous dysplasia, but this one also is found with soft tissue myxoma. So if you see somebody with multiple lesions that look like fibrous dysplasia and a soft tissue lesion, it's near adjacent, and it's a good bet that that's a myxoma, and this patient has a Mazur-Brown syndrome. Multiple enchondromas, so again, a single enchondromas are common benign lesions, often in the hands. Multiple enchondromatoses is a rare condition. Some of the enchondromas in multiple enchondromatosis can look a little more irregular than just kind of your typical solitary benign enchondroma. As you can see here, this patient has multiple of these lytic lesions that are involving long segments of the third metacarpal and phalanges, and also the fourth proximal phalanx right here. These can occur not only in the hands and feet, but also in the long bones and the pelvis and pretty much anywhere in the skeletal system. Um, why do we care about multiple enchondroma syndromes? Well, the main reason is because these patients are more likely to develop malignant degeneration of one of these enchondromas into a chondrosarcoma. Now, it's still pretty rare. The exact number, depending on who you read and what you look at, is kind of variable, maybe ranging from like 5 to 15% chance of malignant degeneration. Um, so that's why we care about these patients with multiple enchondromatoses. Another two syndromes that are associated with multiple enchondromas, one of them is Olier's syndrome, one of them is Maffucci syndrome. The Maffucci syndrome is associated with soft tissue hemangiomas, so you may see phleboliths in the soft tissues from the soft tissue hemangioma, and it's thought that Maffucci syndrome has a slightly higher risk of malignant degeneration than Olier's syndrome. Multiple osteochondromas. This is another polyostotic process. Again, a single osteochondroma, which, if you remember, is just kind of a outgrowth or an exostosis off the bone, and we can look at it and say and see the continuity between the cortex and the underlying marrow, and that is going to allow us to confidently suggest that this is an osteochondroma. Um, so a single one, pretty common. Multiple ones is pretty rare. But again, why do we care about multiple osteochondromas, or the syndrome which is known as hereditary multiple exostosis, or sometimes you may hear it called multiple hereditary exostosis? Um, we care about these because, again, the risk of malignant degeneration is much higher than in a solitary osteochondroma. So the numbers will vary a little bit, but it's going to be in the neighborhood of 100 to 1,000-fold more malignant risk of degeneration than in a patient with just a single solitary osteochondroma. You can see in this patient here about the knee, these multiple osteochondromas, kind of sessile one and maybe a pedunculated one off here in the distal femur, and there's one we're not seeing very well in the more proximal fibula. They share all the characteristics of a normal osteochondroma in that they're in continuity with the cortex and the underlying marrow. One of the interesting things about multiple hereditary exostosis is that if you see one or you maybe see two somewhere else in the body, and you want to know if this patient really has this syndrome, a good bet is to look at the knee. So image the knee, get a radiograph of the knee. If they have them about the knee, you're done. It's a slam dunk. They have the syndrome. For whatever reason, they tend to occur about the knee. And this is an autosomally dominant associated syndrome. So one of the things that's also good to know about multiple osteochondromas is how do you know when one has gone bad? And there's a couple ways to know. Certainly, clinically is one way, is a fair enough way. So if a patient is having pain associated with the osteochondroma, then that's something you can actually worry about. Now, it may turn out that pain is related to another process, or if the osteochondroma is bumping up against a neurovascular bundle and causing pain because of that, or causing osteoarthritis or joint problems because of the altered movement or altered bone growth. But certainly, pain is one thing to think about. Other things to consider is, has this lesion grown? So now, as a child or as a developing skeletal person, they're allowed to grow just like the rest of your bone. But once you've stopped growing, once your growth plates are fused, the osteochondroma shouldn't be growing. So any growth after that fact is worrisome. Um, Radiographically, we can look at the cartilaginous cap. These lesions are associated with a cartilaginous cap. That's the chondroma part of the osteochondroma. Um, as you go into adulthood, the cartilage cap tends to regress and goes away. Um, but we can look at it either on CT or MR, and if that cartilaginous cap is quite large, and uh, people have picked a number of like 2 centimeters on average to use. If it's bigger than that, then we'll start worrying about malignant degeneration as well too. So multiple osteochondromas, autosomal dominant syndrome, um, higher risk of malignant degeneration. So these patients are often placed in a surveillance program of some sort. Multiple non-ossifying fibromas. So the single non-ossifying fibroma is pretty straightforward. We'll see those not uncommonly in kids or young adults, often in the tibia. Remember, these are eccentrically or cortically based lesions. They're geographic with a narrow zone of transition and a sclerotic border. Just like we see here, this eccentrically located lesion, which is narrow zone of transition and has a sclerotic border, maybe slightly cortically based as well. So typical non-ossifying fibroma or fibroxanthoma, whatever you want to call it. There's another one here in the proximal tibia and another one in the proximal fibula. So there is a rare syndrome associated with multiple non-ossifying fibromas, which is known as Jaffe-Combinaci, and this is associated with cafe au lait spots. And sometimes you'll see multiple non-ossifying fibromas in neurofibromatosis type 1. Um, there's no malignant risk of these non-ossifying fibromas. It's just a syndrome that's noticed. It's quite rare, and you're probably never going to see it, but just so you've heard of it. Brown tumors are brown, not really a bone tumor per se. Again, they're really just a collection, a focal collection of osteoclasts, which are chewing up the bone and leaving underneath it this kind of fibrovascular tissue and demineralizing the bone because of the dysregulation of the osteoclast. So brown tumors are associated with hyperparathyroidism, and often you'll see multiple of them. One of your clues that you're dealing with a brown tumor is to look for other manifestations of hyperparathyroidism, which are often pathognomonic, such as in this patient right here, we see subperiosteal resorption along the radial aspect of the middle, second, and third phalanx, as well as some band-like resorption of the distal phalanx here. This kind of band-like resorption, this distal aquaral osteolysis, which is very typical of hyperparathyroidism. And if you saw a lytic lesion in this patient in the bone, then you could pretty much say with confidence that that was a brown tumor. So that's going to be a clue that you're dealing with brown tumors. Just look for other manifestations of hyperparathyroidism. Infection. So again, you can have a single focus of infection, or you can have a multifocal osteomyelitis. There's an entity called chronic recurrent multifocal osteomyelitis, usually seen in younger patients, or you can have a multifocal osteomyelitis associated with fungal infections, tuberculosis, or usually less likely to be a pyogenic bacterial infection, but that is possible as well too. This is a patient right here who has this permeative lesion in the distal radius, and there's a periosteal reaction, not only about the radius, but about the ulnar. This was a focal area infection, but they could be other areas of infection and a multifocal infection. So that's something to consider as well. Langerhans cell histiocytosis, or EG, another rare condition. You'll see this in children or young adults. You're not going to mention this in a differential in older adults because it just doesn't really occur. Um, so this is something to think about when you have a patient in the right age range and you have multiple lytic lesions. As you can see here, there's one, there are multiple in the vertebral bodies. This patient had other ones also throughout their skeletal system. And this was a young woman with EG. Sometimes EG can look very aggressive and scary and mimic something like a lymphoma or other more aggressive process. All right, malignant polyostotic conditions really again just boils down to metastasis and multiple myeloma. Those are going to be the main things that are going to do it. This was a technetium 99M MDP bone scan in a patient with multiple skeletal abnormalities, multiple skeletal metastasis, and soft tissue metastasis. Their primary in this case was actually an osteosarcoma. Was here in their proximal tibia, and then it had metastasized all over. But certainly metamyeloma, myeloma usually tends to occur in adults over 50 or so, not so much before then. So if they're under 50, you may leave myeloma out of your differential. Um, Metastases that like to be expansile lytic tend to be thyroid and renal, so that's something to think about too. If you see multiple expansile lytic lesions from metastasis, things that can do that are thyroid and renal metastasis. All right, so the miscellaneous conditions, hemangiomas, osteopoikilosis, and melariostosis. Hemangiomas, you see these in the spine all the time. They have this typical corduroid appearance, as you see right here in this vertebral body. They're benign, they're incidental findings, these don't mean anything. But you can have conditions where you have multiple hemangiomas throughout the bones. It's uncommon, but possible. There's no malignant potential to any of these. Osteopoikilosis is a skeletal dysplasia where you have multiple bone islands, as you can see in this patient right here, multiple sclerotic foci scattered throughout the pelvis. These were all just bone islands from osteopoikilosis. Um, Occasionally, if a patient has like an underlying prostate cancer or something, and you're worried that these are metastases, it's reasonable to perhaps take them to do a bone scan to see if they have any activity within them. The activity is variable on bone scan, but they tend not to have much uptake on them. So, one other interesting factoid about osteopoikilosis is these patients are prone to keloids, which may not affect you that much, but if they're undergoing a procedure of some sort or if you're doing an intervention on them, that's nice to know. Try to minimize scar in these patients if they have osteopoikilosis. Melariostosis is a skeletal dysplasia which runs along sclerotomes. Here you see these sclerotic bands kind of and cortical thickening extending along the humerus. It's also the sclerosis of the scapula. Um, Typically, melariostosis is described as a dripping candle wax appearance going along the bone. And you can see that either isolated in one bone or in multiple bones as well too. There's no malignant potential to melariostosis, but it can be painful and can cause problems if it crosses joint spaces or rubs against a neurovascular bundle or something.